In this video, we'll discuss clinical features of the Crohn's disease. It may be acute or chronic inflammation, may be fibrostenotic that leads to obstruction, and number two, it may form fistulous tract. So, acute or chronic inflammation, fibrostenotic or fistulous. The clinical features of the Crohn's disease depend on the site of the lesion. Most common site is a small intestine. So, let's discuss ileocolitis first. So, 30 to 40% patients have a small bowel disease and 90% have terminal ileal disease. The lesions in the terminal ileum, they mimic acute appendicitis with pain, low-grade fever, and mass in the right lower quadrant or right iliac fossa. So in ileocolitis, 90% is in the terminal ileum, and the features mimic acute appendicitis with pain, low-grade fever, and mass in the right lower quadrant or right iliac fossa. If the fever is high, then it indicates an abscess formation. Persistent inflammation decreases the luminal diameter and distensibility that leads to fistula formation. So first there is decrease in lumen diameter and distensibility, and then fistula formation. Fibrosis, thickening and narrowing of the GI wall causes radiologic features of string sign. Inflammation of the ileocecal region causes microperfusion and fistula formation. Fistula may communicate with the other organs, and it may be enterocutaneous fistula. A bladder fistula causes nematuria or fecaluria. A fistula in the vagina, enterovaginal fistula, causes painful vaginal discharge and dyspareunia, pain on coitus. Now, clinical features in jejunum iliatus. Jejunum and early small intestine is the site where maximal food absorption occurs. So a lesion here will cause malabsorption and steatorrhea, and diarrhea is characteristic of this lesion. There may occur hypoalbuminemia, anemia, niacin deficiency, pellagra, hypocalcemia, vitamin D deficiency, vertebral fractures, and fat-soluble vitamin deficiency. So lesion in jejunum and ileum causing malabsorption is steatorrhea and deficiency of many substances with hypoalbuminemia and fractures due to the deficiency of calcium and vitamin D. Terminal ileal disease causes bile acid and B12 malabsorption, as I earlier mentioned that they are absorbed from there. B12 deficiency causes megaloblastic anemia and neurological features. So what type of neurological feature? B12 causes posterior column defect. We have a separate video on vitamin B12 deficiency. Please watch it for further details. For absorption, B12 also requires intrinsic factor from the parietal cell of the stomach. So a lesion in the stomach may also cause B12 deficiency. Now, colitis. Features in colitis: hematochezia and toxic megacolon are less common than in ulcerative colitis. Stricturing in colitis leading to intestinal obstruction, and that occur in 5 to 15% of cases. Rectovaginal fistula occur in 10% of cases, and it may fistulize to the stomach, duodenum, and small intestine. So in colitis, fistula may occur to many organs including vagina, stomach, duodenum, and in small intestine, and there may occur intestinal obstruction in 15% of cases. But hematochezia and toxic megacolon in Crohn's disease colitis are less common. Now, perianal disease clinical features are incontinence, stricture, peripheral abscesses, and anorectal fistula. The lesion in the gastroduodenal area will cause pain, vomiting, and H. pylori negative gastrite. And also I told you B12 deficiency because intrinsic factor will be